Good afternoon, everyone. Welcome to this webinar. It's really very exciting to be here today to talk about the mental health of healthcare workers. We know that they are really the cornerstone of any healthcare system. They are the caregivers, and quality is deeply dependent on how well they do their work. And as we know, we really cannot expect them to draw from empty wells. So their ability to perform and provide quality care depends on their wellness in itself. So I think this is a very vital discussion. Now, this discussion is anchored around the work done by the Uzima Data Science Hub. The Uzima Data Science Hub is actually a hub whose focus is how do we harmonize data? How do we look at longitudinal trajectories to really come up with indicators of early warning for poor and really predict poor outcomes in two specific areas. The first area is maternal, newborn, and child health. Like how can we look at data and say a woman A in Kilifi might be at a high risk of poor outcome, and then really work out how best to provide early intervention, since we know early intervention can lead to better outcomes. The other aspect of Uzima data science, which is part of the reason we're here today, it's really to look at mental health. And again, develop predictive models using AI and machine learning so that we can know the early indicators of poor mental health. We can know who is at the highest risk and be able to implement early intervention. So we find that in the last 2 years, the Uzima Data Science Hub carried out a longitudinal study to look at mental health of healthcare workers. And today, it's our pleasure to really be able to disseminate those findings and work with the experts and practitioners from the field to discuss the implications of those findings and how best to address the mental health of healthcare workers. I have 3 very able panelists. It's my pleasure to invite them and to introduce them. The first panelist is Dr. Mercy Karanja. Dr. Mercy Karanja is a consultant psychiatrist, and she is the director of mental health at the Ministry of Health Kenya. She's the secretary to the Kenya Board of Mental Health and the president of the Kenya Psychiatric Association. She has a lot of achievements, and you can see that on the slide. Dr. Mercy, thank you so much for making time to be here and all that you do for the mental health space in Kenya. Our second panelist is Faith Karimi, of Faith Mushena. So Faith is a senior physiotherapist at Kasarani Health Center. She has more than 20 years of practice in both public and private setting. And she's really here to talk about some of the day-to-day experiences she has being a practitioner who is very much in touch with how healthcare workers feel and experience mental health, and especially women's health. Yeah? Then we do have Professor Lukoye, the third panelist. He's the Dean of the Medical College East Africa and the Deputy Director of the Brain and Mind Institute at Aga Khan University. Prof. Lukoye is world-acclaimed psychiatrist with lots and lots of achievement. Currently, the international president of the World Health Summit, an honorary professor at University of Cape Town, and I wouldn't want to go through all his achievement because we could take a whole hour on that. Please welcome the 3 panelists for this discussion. Thank you. So I'm going to start by asking Professor Lukoye the first question, which really is, what made the Uzima data science be concerned with the mental health of healthcare workers? What was the urgency there?
Thank you very much, Amina, and thank you everyone who has made time to come and listen to some of the findings that we are seeing from the work we are doing with our health workers here in Kenya. Firstly, when we were designing this study, we were alive to the fact that a few other studies had been carried out over the past 5 years or so, looking at the mental health of health workers. And all of them had been coming up with relatively alarming findings. So there's a study that we carried out at the beginning of COVID-19, before the effects of COVID-19 had been felt among health workers. And in that particular study, found very high rates of mental illnesses, with depression showing up at around 1/3 of the people that we surveyed had significant symptoms of depression. Now, in the middle of the COVID-19 pandemic, a group of colleagues, again led by Dr. Shah, who is on this webinar as well, conducted a similar survey, again, among health workers who are involved in taking care of patients with COVID-19. And at that time, the study revealed, again, very high rates between more than 25 to 40 to 50% of a variety of mental illnesses, with depression showing up at 52% or thereabouts in the population of health workers that were being surveyed. And so we realized that we had an issue among health workers, and many, many studies had been published about burnout among health workers at various levels, various cadres, and so on and so forth. And so we thought that, firstly, it is established that the mental health of health workers is an important thing to study, because you need your health workers to be mentally healthy in order to be able to provide quality health services to the people that come to us. And then secondly, we acknowledged that there is a high burden, although it is not well quantified, but there's a high burden of mental ill health among health workers right from the beginning. And the third thing was that we do not seem to be aware of what are some of the things that we can use to predict when we have a group of health workers. What are the things we can use to predict who's going to be in more problems than the other, so that we start providing the supports early and avoid a situation where people get critically ill and therefore affect their ability to work and access to health for other people. So those motivated our thinking that one of the things that we're going to do in our Uzima study is to look at the mental health of health workers. And what are we going to do? We are going to recruit them from a variety of facilities, and then we would have multiple data points. So we decided that it's not just one questionnaire that we can use in order to make all those determinations that we are interested in. And so the first thing we agreed is that we would have a longitudinal follow-up study, so that we collect data from the same individual over multiple time points. And then we collect from a large number of people, so that we can then use that data that we have collected to look at trends and to look at some of the factors that are modifiable, some of the changes that happen in the course of a year as a health worker continues with their tasks. And the second thing is that we say the questionnaire is not enough. And so we decided that there's other data that probably influence the mental health status of an individual that we don't routinely collect during these surveys that we do in mental health. And this include data about, sleep. So we ask very flat questions about sleep. How long do you sleep? Do you wake up at night? Do you have difficulty going to sleep, and so on? But these are questions that are very flat, in the sense that somebody might have those difficulties today, but not yesterday. They might not have them today, but tomorrow they start having them. And so it is difficult for you to correlate whatever you learn about somebody's sleep from one encounter and try and use that to determine whether they're at high risk of depression or not. So we decided that we will collect data about sleep, we will collect data about activity, and so on and so forth. And that necessitated using wearable devices in order to collect that data and send it to the database. So collecting this huge mountain of data was necessary, because, as Amina indicated, this was a data science project whose aim was to leverage machine learning to start developing models that would help us to determine those who are at high risk and what we can do for them in advance before problems set in. And so we collected, a variety of data because of that. I hope, Amina, I have demonstrated what motivated us and what we set out to do as a result of that motivation.
Thank you. I think that's a really good summary, which leads us to Faith. As a clinician who sits in a very busy setting, I would like you to tell us a little bit on what stress looks like on a day-to-day basis, and what the silent pressures healthcare workers face, so that we just move from the research work to really what it means on a day-to-day basis.
Thank you very
Over to
much,
Faith.
Professor Amina, for having me, and thank you for that question. Definitely not answering it from a point of, speciality, but from a healthcare perspective. And in my lens, stress for healthcare workers can mean constant juggling with high volume of patients. And this is something that has been there since time immemorial. There's never ever occurred a period in time that healthcare workers have, staffing ratio that is adequate. And things like lack of collegiality, most of the healthcare workers would feel maybe your colleague is not supporting you to achieve the goal of the team. And also things like things that could also be ignored, poor or non-functional welfares at workplace. And these ones make our colleagues feel like they lack belonging at the workplace. We also have, especially for a public setting, where we have a lack of adequate spaces, where colleagues are having to share rooms, colleagues are having to share workspaces, and this one will, of course, hinder privacy, and it can increase the stress of a healthcare worker silently. Also, there's another silent stressor, which is the age gap at workplaces. And we find that because at our workplaces, we have different generations at work. We have Gen X, we have the millennials, and even the Gen Zs now at workplaces. And you find they are unable to gel, they fail to identify with each other. The millennials cannot understand how Gen Zs function or, work. And this can also escalate stress issues among healthcare workers. Other things definitely would mean like, other silent stressors for younger healthcare workers are things like fear of making mistakes. You've just come from practice, from training, and you've come immediately to start practice, and you're so scared to make a simple mistake. And that could also increase a stress for a healthcare worker. And something else is also the lack of work-life balance for healthcare workers. Most of them are carrying work to their houses, and continuing with a lot of stress even to their homes, or even carrying house stress to the workspace. In Nairobi County, especially, another silent stressor is, the continued demotivating factors like delayed pay, lack of proper health insurance channels, or even career progressions. And definitely most of healthcare workers, especially in Nairobi County, can relate with what I'm actually saying right now. Yeah.
Thank you, Faith. That was actually a lot. If I heard you correct, you talked of personal issues to interpersonal issues, structural problems, resource at the institution. So it's quite clear that the healthcare workers have to deal with a lot, and the workload is also not very light. This brings us to Dr. Mercy, and really to ask what national or institutional policies are currently available to support the mental health of healthcare workers. Where do you see the strength? But also, where do you see the gaps where we can really enhance our policies?
Thank you very much, Prof. Amina, and thank you, my fellow panelists, for this insightful discussion that we're having today. If I'm to start, as a country, really, our Constitution, Article 43, upholds the right to everybody having the highest attainable standards of health. And as we know, health is defined to be inclusive of mental health. And further to that, our Mental Health Act also ensures that we have access to mental health services for all Kenyans. So I think before the COVID-19 pandemic, a lot of healthcare workers had really ignored their own personal well-being. As mentioned earlier by Prof. Toli, the study they conducted back then it really started bringing out to most of us the need to also be cognizant of our own mental health struggles, the stress and burnout that we face at the workplace, especially seeing that we were the people who were left at work when everybody else was in lockdown. And at that point, that is where also our policy journey towards addressing the mental health needs of healthcare workers started also at the ministry. Of course, the Constitution had already put a framework to provide healthcare for everyone, but now we focus specifically on mental well-being of healthcare workers. And we did develop a comprehensive guide on managing mental health and psychosocial support for healthcare workers. And that time it was tailored really towards the response to the COVID-19 pandemic. But beyond that, now we realize that we need to broaden this beyond COVID-19 because these are real struggles that happen every day for the healthcare workers. And in 2023, we developed a guideline on mental health at the workplace. So there's a national guideline on workplace mental wellness. Initially, we were focusing on healthcare workers. Then we realized that we need to have an approach that addresses all workspaces. But now, moving forward, it was adopted across most workplaces. And since we sit in health, our division sits in health, we were deliberate to ensure that this also is implemented in most, in at least in the healthcare spaces. A good example is, for instance, Mathare National Teaching and Referral Hospital that embraced this policy and developed a plan for their workers. We have several counties that we have supported to develop workplace mental wellness programs for their healthcare workers. And this has gone to show that when you address the mental well-being of healthcare workers, even the outcomes of the patients are good. So I can say one of the strongest things we have in our country policy-wise first is that our constitution is very supportive of ensuring that the healthcare of all Kenyans is assured at the highest level. Our Mental Health Act also ensures that we provide access to the services, and even our mental health policy and mental health action plan provides for an overall framework for promoting mental well-being in all workplaces. And then, of course, our national guideline. Now, another thing that happened also is because of the high level of demand for mental well-being at the workplace and even demand for services under the State Department for Public Service, we found that they realized that healthcare workers and civil servants in general were seeking health services, mental health services at an alarming rate. And they conducted a survey, although it was not tailored purely to healthcare workers, but really from that, they told us that we need to develop or to have committees within the workplaces and within the state departments and ministries that handle workplace mental wellness. And you find that MDAs that are dealing with healthcare workers are now mandated to have at least a committee addresses mental well-being of the healthcare workers or the workers in their spaces to ensure that they remain productive and also their well-being is maintained. So those are the strengths that we have in terms of policy and our guidelines. Although, of course, we may not have achieved coverage in all the places, there's still a lot of challenges, especially in terms of having the necessary resources, ensuring that access is guaranteed, and we are addressing the stigma issues, which is one of the biggest challenges that hinders even people seeking help. So we still are struggling with some of those challenges, and we hope that we can move beyond them and we can allocate adequate resources for addressing the mental well-being of our healthcare workers. Thank you.
Thank you. Clearly, a lot is being done. I wonder if we have a way to monitor the implementation. So it's clear there are policies. For instance, do we have a mechanism to know how many of the workplaces are actually implementing these policies and setting up the necessary committees to support mental well-being?
So now, unfortunately, yes, that's another gap, that we do not have a system that monitors how many workplaces, because workplaces are quite diverse, and we really because healthcare workers are really under the county government system, we left that responsibility after supporting them to develop the programs. But at national level, we have that gap that we have not established a common informatics system that can gather to us the data of, are those services established? Are they being utilized? What is the findings from that? So we really need to do better and come up with them a dedicated national monitoring system focusing on the mental well-being of the healthcare workers. So that is a gap that needs maybe investment and better structuring so that we can also get lessons that can also help us improve our policies.
Thank you, Dr. Mercy, for pointing out the strengths and some of the areas we need to focus on. Now, I would like to go back to Professor Lukoye. If really you can give us a highlight of what are the key findings from Uzima, given what was previously known and what is currently being implemented. What did we observe?
Yeah. Thank you very much. So we looked at a number of mental health indicators, but I'm going to focus on depression because it's like one of those things that if you go into a society and find it, it means there's a whole world of people with psychological distress in that population that are probably not yet identified. So depression can be a signal that helps you to figure out whether people are accessing mental health services or not. And so focusing on depression, then we had more than 500 people that we recruited, health workers that we recruited from a variety of health facilities across this city in Nairobi. And we tracked them over a period of 12 months. And over that period, we did a baseline assessment. We did an assessment at 3 months, an assessment at 6 months, 9, and at 12 months. Obviously, we started with a large number, but by the time we're finishing, we had about a third of them still engaged in the study by the time we reached the end. And that attrition is one of the features of longitudinal studies. And it is one of the things that we study to figure out how do you keep people engaged for a longer period of time. If I have an intervention that requires somebody to have a wearable and to keep sending data regularly, how long can they remain engaged? And that is one of the things that we're studying. But focusing on depression, we found that at baseline, at the beginning of the study, about a third of the participants had significant symptoms of depression as measured by the PHQ-9. This means that scores of 10 and above on that scale. And then at 3 months, about 26%, at 6 months, 21%, at 9 months, 22%, and at the end of the study, with the attrition that we had 18% of people still having significant symptoms of depression. If we look at all time points and say how many people at any time point met this significant threshold for depression, we found more than 43% of our study sample met the threshold for significant depressive symptoms in the course of this study. And so these are huge numbers. Even if you took just 20% of our health workforce having significant symptoms of depression across the study period of 1 year, this is a significant finding. And then we looked at what are some of the factors, because we were looking at the trajectory of the symptoms that the patient, that our health workers were displaying in the course of the study. And looking at the trajectory, we asked ourselves, because it's a longitudinal study, what are the factors that are associated with increasing scores over time? So that if you had a score of 6 at baseline, what determines, what is the factor that determines whether you will have a score of 10 or 15 or 20 in the course of this study? Because those are the things we are interested in, to see what are the things that increase distress so that we can focus on them and see which ones are modifiable. And as Faith just mentioned, one of the factors that shone through as a factor was workplace discrimination. So if somebody felt discriminated against at the workplace, they were more likely to have rising scores of PHQ-9 over the study period. And this is significant because it is something we can do something about. Another factor that was associated with the rising scores was stressful life events. So people who reported having stressful life events in the period preceding the time when we did the survey also demonstrated rising scores on PHQ-9 over time. The other thing was relationship status. So people who are not in a stable relationship, people who for all intents and purposes were alone, would have higher risk of having their scores increase compared to people who are in a stable relationship. Then the other important factor was a difficult early family environment. And so this tells you something about the things that happen when we are being brought up, when we are growing up, and how this affects you as an adult. So people reporting early childhood difficulties or a difficult environment in their family growing up were also at higher risk of having their scores increase over the course of the study. And finally, personality traits are also a factor. And one of those traits is what we call neuroticism, was associated also with increasing scores over the course of the study. So these are some of the factors that that are associated. And this is the beauty with a longitudinal study that is going to use machine learning techniques to try and tease out these factors so that when we are doing an intervention, we can work on them. One of the things that we learned in this study was about this attrition. So one would expect that if you go to health workers, engage them as we did, because we did quite a lot of engagement, give them a wearable, have regular contact with them, that you would retain a significant proportion of them in the study. Unfortunately, we had similar attrition to many longitudinal studies where we ended up with about a third of those that we started with. So this is something that we have learned. Other things that we've learned in this study included the factors associated with the wearable device itself. There are people who would say it's uncomfortable to sleep with it on their arm, or that there are times it loses network and doesn't sync with the system, or it doesn't send the data, or it runs out of charge and they have to find a place to charge them, and so on and so forth, or that the network is not so good, and so on. Then we had challenges with retention of the devices. There are some people who lost those devices, and so we had to figure out ways of whether to replace them or whether that was part of the attrition. And then obviously the challenge of participant dropout. So those are some of the things that we learned. And we have attempted to do some qualitative analysis to help us understand these factors a little more, which we will be publishing in our work later. However, just by way of summary, significant numbers of our health workers reported very, very high levels of significant symptoms of depression. A good number of them had those scores rise over the course of 1 year. And we identified some of the factors that are associated with a rise in those scores. Amina.
Thank you, Prof. I will want to chat with you a little bit before we move on. The first one is because we can't get half a human or 3/4 of a human. My assumption is when you talk about 43%, what you're telling us in a very simple terms is that if I had 2 healthcare workers, one had a very high chance of having experienced depression over the period of 12 months. Is that a correct interpretation?
Yes, so we are saying that out of about the 500 people that we recruited at baseline and then tracked them over the period of 1 year, 43% of them, so that would be more than 200 of them, had at least one time point where they met the criteria for depression. So that is what it means. So yes, if you have 10 people, we are saying that if you track them over 10 years, you are likely to have 4 to 5 of them having significant symptoms of depression at any time point in the course of that year. If you have 100 people, we are talking about 40 to 50 people displaying significant symptoms of depression over the course of 1 year. So this is, I think, an important observation from this work. Yeah.
It's quite high and very alarming. The other thing I would want to chat a little bit, you talked about neuroticism, a personality trait. Do you want to just spend a minute or two telling us? I'm just trying to make it as concrete as possible for everyone on that.
Yeah. So neuroticism is a certain personality trait. So they put dimensions on personality traits, and the study of personalities is another whole long story that is probably not useful here. But then neuroticism is about somebody who tends towards the obsessive compulsive side of doing things, where you want things done in a certain way. You get anxious when things are not working out in a certain way, and so on and so forth. You get obsessed with the things being done in a certain way, and so on. And so you are more likely to internalize some of the things that are happening there, to experience them inside, and sometimes to tend to blame yourself, and so on and so forth. So those are factors that indeed, if you're in a high pressure environment and you have this neuroticism, then they increase your risk of having depressive symptoms, because it's part of the pathway towards depressive symptoms.
Yeah, I thought that was important to just raise, because when you're thinking of intervention, it has to be multi-component. There's individual factors.
Absolutely.
Okay. I want to also take another second on wearables. I think this is really an exciting part of Uzima, and it's something new, and it really tells us about the potential of technology in mental health. Can you just kind of comment for a minute on that?
I think as time goes by, we have learned, and this is happening in every domain of health research. As time goes by, we are learning that the more data you have about an individual, about a population, the better you are able to predict what's going to happen to them, and the better you are able to predict what's going to be helpful for them. And we are learning that the data is not only the data you give me in the clinic when we are sitting across from each other and you tell me, last night I didn't sleep well and so on, but it needs to be data that creates a pattern that we can then use, and we use that pattern in order to understand what are the things that are causing distress and problems. And that data includes data that you might not even be aware of yourself, like the pattern of your sleep. You go to bed, you close your eyes, and you wake up in the morning. But there are things that happen in the course of the night. You wake up sometimes. Sometimes you spend time in deep sleep. Sometimes it's in light sleep. You are restless. You're moving around. That data can be collected with a wearable device, and it can help us to make certain predictions. When you're walking around and you're going to work and you're doing your daily activities, you don't count the steps that you're doing. So we don't know what level of activity is helpful, what level of activity denotes that this person's activity has reduced from here to here, and therefore their risk of depression is now increasing. We don't know. But with wearable devices, they can track your movement, they can track your heartbeat, they can track even your respiratory rate, your sleep. Sometimes you can even track how much exposure to the sun are you having. And that data, we are finding that when we add that data to the questionnaire data about your mood and how you're feeling and how you're thinking and so on, and we pool that data, that we are able to make better diagnosis, we are able to make better predictions about the course of your health, and we are better able to predict what is going to help you and what might not be helpful to you. So this is, I think, where we need to go, because more data makes our diagnosis more accurate, makes our predictions more accurate and more helpful to the people that we are trying to help. And Uzima is leading the way in establishing the utility, the efficiency, and ultimately the effectiveness of using these devices in getting that data to help our patients.
Thank you. I think the combination of active and passive data is really a methodological innovation for this study.
Absolutely.
Thank you, Prof.
Absolutely.
So, Faith, I want to go back to you, because you've had all this that Prof has said, which is just really a snapshot of what we found. Are healthcare workers comfortable talking about stress, burnout, and emotional strains? What makes it easy or difficult to discuss these, issues in the health setting?
Thank you, Prof. Amina, for that. And I'm very perplexed to learn about the number of dropouts in that study. As somebody who was in that study, I took it with the seriousness that it required. I actually took it like my life depended on it, and actually it did, because I'd actually come from having PTSD because of very grisly actions I had had during that time of the study. And I was very particular in following up. You see, like Prof. Lutoya has just said that one of the indicators that was coming out very strongly as a big stressor was stressful life events. And of course, to me, having an accident was a very big life event that was stressing me so much. It had left me with so many mental issues. And I would like to say, coming back to your question about healthcare workers being very open to speaking about their mental health challenges, I would clearly say that there's seldom safety in speaking up. And this one does not apply to healthcare workers only. It is actually for most people feel very reserved to talk about their issues. Some of the factors that hinder people from speaking, and especially healthcare workers from speaking up on the mental health challenges facing is, there's no safety in speaking up. People will fear that when they speak up about what is stressing them up or talk about stress and burnout, they will be stigmatized at the workplace. And of course, this one will have a huge impact even on their careers, because people will say, this one is tired with work. This one does not want to work. And this person is going through extreme stress that is even affecting service delivery. Another factor that could make healthcare workers not to speak up could be, things like time constraints. As we said earlier, these high volumes of work, high volumes of patients, and there's no time to sit and talk how you're feeling, what your mental state at that particular time. There's a lot of workload for you to, and timelines for you to manage your work. So you put your stress aside. Another factor could be, a lack of awareness of the mental health issue that you have. We are just moving out day by day thinking, maybe I'm just stressed a little bit, but probably it's a heavy mental health challenge that you're having, and you do not know. That lack of awareness about that mental health issue that you could be facing could hinder you seeking or speaking about mental health. Another one that I think is also a silent monster in the room is personal biases. Most of us, and especially healthcare workers, have personal biases on effectiveness of counseling services. We all doubt how counseling can help you deal with or deal with life challenges. And somebody will be saying, why would I go to a counselor just to tell them what I know about myself? And I am speaking this as somebody who have thought that before, and also as somebody who has also have had counseling services that helped me to cope with a life challenge. So these are some of the factors that could be hindering healthcare workers. Others are fearing, if I speak, I'll be victimized. Others are fearing, if I speak, I will be seen like as a lazy person or not a very strong person, and we have this culture of telling people, be strong, just move on, things like that. Yeah, I think that is one of the things that, yeah.
So just because of time pressures, I'll give you only 1 minute to just list. If you could change something in the healthcare system to support healthcare workers, what are the 3 top things? And if you can't think about them right away, I can go to Dr. Mercy and come back to you on that.
If that ability, one of the things that I would change would be, better staffing ratios for healthcare workers to reduce burnout. Another thing would be regular trainings on mental health related stress and also stress management, and also regular mental health check-ins with counselors.
Thank you. I will now want to go to Dr. Mercy. And here I would like to just know, are there any existing mechanisms for the ministry to monitor healthcare workers' well-being? If not, can you think of what would be realistic for us to be able to monitor healthcare workers and really scalable?
Thank you so much, Prof. As I said earlier, unfortunately, we do health that allow us to be able to monitor the healthcare workers and their mental well-being. I know a lot of times at the level of service delivery, we are monitoring more of the performance without monitoring the factors or the determinants of the performance. So you'll find a lot of human resource information systems are centered around performance. So that's a big gap. What we need to do is improve the existing human resource for health information systems for the healthcare workers and the employees to also incorporate aspects of their well-being and their occupational health. And that way, we are able to see, even when we are planning to set up programs, they're informed by what is the issues on the ground other than just going blindly. So there is a gap there, but the implementation level and in the counties and at the national level, and we could perhaps include having staff giving even anonymous surveys, subjected to anonymous surveys, where they just give feedback about what they feel, what has been mentioned here by Prof. Lukoye and Faith, about some of the issues that people are facing, and I've also seen it arising in the Q&A about burnout, workload, satisfaction with the workplaces. Can there be periodic staff well-being surveys at the workplace as a starting point? Because that's something can even directly inform the administration on the ground. Then having committees, like I said earlier, the State Department for Public Service recommended that there be workplace mental wellness committees, and that is also a recommendation that is under our national guidelines on workplace mental wellness, that can we have workplace mental wellness committees and also have appointed mental health advocates within the institutions who can be concerned with, of course, doing this monitoring, because sometimes people may not be very open towards admin, but have these committees in place that are charged with the responsibility of even monitoring and even enforcing or putting in place programs for mental well-being. Then availing confidential psychological support. Faith has raised a very important issue that stigma is the one that is one of the biggest driver for people not talking about it or expressing what they are going through when it relates to their mental well-being and mental health issues. So can we expand those confidential support systems? Can we have better awareness system, creating awareness to the employees on the need to prevent illness, promote their well-being, and the existence of support, so that they can also utilize the services when they are availed to them. Sometimes we set up these services, but it's not communicated adequately to the employees and then the healthcare workers, so they go unutilized. Digital innovations and wearable technologies where resources allow, like what was done in the Uzima study, can also be a good way, but as we know, those ones require expanded resources. So, and of course, ensuring that whatever surveys we are conducting, whatever services we are providing, whatever data we are collecting, it is meant to be supportive and not seen to be something that's punitive. And this will allow healthcare workers to feel confident and utilize the system. As you've heard from Faith, that is one of the biggest hindrances, that if I report, there might be punitive measures taken against me. So if we do create trust with our healthcare workers when we are providing these services, when we are taking the surveys, they are more likely to be open, and that way we'll build systems that are actually able to meet the needs of the healthcare workers. Thank you.
Thank you. The last question will go to Professor Lukoye. Based on the findings of this study and today's discussion, what would you propose to be what the healthcare system policymakers should prioritize to better protect healthcare workers?
Thank you very much. I think in every sector, people talk about taking care of yourself first, and the health sector should not be different. Historically, the health worker has been thought of as an altruistic individual who gives their all, often to their own destruction, in order to protect others and to save others. But today we say you have to be healthy in order for you to be able to provide good service, in order for you to protect the health of others. So we have to have mechanisms at workplaces that ensure, firstly, that there are wellness activities and opportunities for people to engage in wellness activities, including encouraging healthy lifestyles at the workplace. Secondly, there should be access to activities and opportunities to improve mental well-being, including group sessions, including opportunities for people to speak to someone when they're going through something difficult, even if it is not a therapeutic interaction, an opportunity to speak to someone when they have gone through something difficult. And thirdly, there has to be a pathway to care for our health workers who start developing mental distress and ultimately develop mental illness. There has to be a pathway to care that is trusted and a pathway to care that is effective. In many places, if it's a hospital, you may have on-site services, but you should also have the possibility of having this health worker go somewhere else to get help when they need it so that they can come back when they are well. So above all, you need a policy framework, even at the workplace, that prioritizes the mental health of the workers in our health facilities, in our health system, and that then provides for all those things that I have said that need to be available to everyone in order to ensure that our health workers are mentally healthy so that they can provide the quality services that the Constitution demands of them and that the population demands of them as well.
Thank you very much. I think that has been a very enriching discussion. We've actually spent more time than was planned, and we do have questions from participants. So I'm sorry that we may not be able to answer all questions, but I would like to get a few minutes to discuss some of the issues participants have raised. And I will just take one of the first one I've seen. I think that will go to you, Professor Lukoye.
Mm-hmm.
One participant asks that we have very high rates because we used PHQ. Do you think it would have been slightly different if we used the mini? And maybe you could just explain to Nini the difference between the two. Thank you.
Yeah, I want to agree 100% that the PHQ-9 is a screening tool. And the PHQ-9 should not be used to make treatment decisions. Absolutely, because it will be over-inclusive. So it will have higher rates. And then when this person who has been identified with the high scores, they still need to go through an evaluation by a professional who will then determine whether they actually have depression or whether they have something else and something else that are adding up to look like depression. So it is important to acknowledge that this is a screener, and ultimately people who are identified by this tool, they require to go to a professional to have a proper evaluation and a diagnosis made and a plan made for them if they need it. However, it helps us when we are rapidly assessing a large population to identify people who are probably at risk so that they can get care. The mini is a tool that is aimed at approximating a clinical diagnosis. So it attempts to arrive at the same conclusion that a psychiatrist or a professional trained in diagnosing depression would arrive at by using a very standardized questionnaire with very many questions that ultimately then are added up to meet the DSM-5 criteria for depression. And that would give you, definitely if you use that on this population, you'll get probably lower rates, but the people you will get will be clinically diagnosed as having depression, requiring some kind of intervention. So that is true.
So this will go to Faith. The issue of workload. To what extent do you think the workload and the culture? So someone here says that healthcare workers are told to sacrifice a lot. Do you think there is a culture in the way healthcare workers are trained that impacts this? And what do you think we can do about the workload and the culture? Some practical tips.
Yeah, thank you for that, Prof. Of course, we are cultured in that way, and it's very unfortunate. Some of the strategy or, things that you can do as a healthcare worker to help you curb burnout and stress-related, work-related stress is, like taking small breaks from the workspace to just even 15 minutes or 10 minutes to go and get a fresh air or breathe and also allowing ourselves to have enough sleep. Just like the Uzima project was very keen on how much we are sleeping and the quality of the sleep we are having, it's very important for a healthcare worker to employ that so that they can be able to handle those kind of volumes. Besides that, the others are just institutional challenges, like now the ratios of staff to patients, and that one is usually beyond you. Yeah.
And Amina, if I may just chime in, because it's related to this, that in this study, we actually looked at what one might say is excessive workload. Like we looked at work hours, okay? And we tried to see whether work hours are also correlated with an increased risk of rising scores in depression. And there was no association. So in other words, this is one of the things that you find when you do a longitudinal study, that you're tracking people at multiple time points. You find that the things we think are obvious recede in importance. So instead of work hours, we are looking at a person who feels discriminated against in the workplace. And that probably includes the work hours, but includes multiple other things that are making this person feel marginalized. And that is a bigger risk factor than just work hours alone. So I think that is the importance of a study of this nature that collects multiple time points of data and collects a variety of data more than what we collect clinically.
Actually, that's so interesting because it reminds me of another study we did. We are just about to publish it. And actually, it was not the amount of money healthcare workers earn that was a problem. It was the lack of regularity. The fact that sometimes they would get, sometimes they wouldn't get. It would be 3 months, it would be 4 months. So I think longitudinal studies really help disentangle the key issues. Yeah. So, Dr. Mercy, what can we do to fill the policy gap? That's what somebody asks, that you've really outlined quite a few gaps. One practical way we should fill the policy gap.
Okay, all right. I think one of the practical ways is to take it beyond the national level to county level and then institutional level. Because number one, when we make policies at the ministry, we do not implement those policies. We count on the county governments, who are the employers of the healthcare workers, to implement these policies. So the most practical way is ensuring that these policies are disseminated all the way to the service provision level, and beyond dissemination, they're actually turned into actions that translate to programs that benefit them, the healthcare workers. If we do not do that, then they'll not be beneficial. And aside from that, we should also have a mechanism of monitoring. Like I said earlier, monitoring what the impact of these policies to the healthcare workers, so that we ensure that they are actually working for what they were intended for. I want to point out something. I'm sorry to respond to a question you asked earlier to Faith, that please remember, as much as we hide behind institutional culture, the Constitution, Article 41, guarantees us of fair labor. So we need to demand as healthcare workers to have fair labor working environments. So it is our right as healthcare workers. So don't just adopt into institutional cultures that have been carried on for many years, and you just feel like you're helpless. So remember, the Constitution also protects you when it comes to your working environment. Thank you.
Thank you very much. So we have lots and lots of questions, and I don't think we can answer all that. We will disseminate the study findings. Some have already been published. We are preparing a policy brief, and we will be sure to send to all those who have attended this seminar. I would like to thank you all for your questions, and sincere apologies that we don't have enough time to do it, to answer all of them. I would like to give each panelist 1 second to give us their parting shots. So I will start with you, Faith, then Professor Lukoye, then we will let the government representative close for us.
Thank you very much, Prof. My parting shot would be to all of us. We usually ask healthcare workers to carry the pain of others, and we forget that they are humans too. So caring for the caregiver is not actually a luxury, it's a necessity, and it forms part of a healthy system. Thank you.
Thank you very much, Prof.
Yeah, thank you very much. As we always say, there's no health without mental health. So even our health workers, as they agitate to have better medical cover at the places of work, better access to health services, they must ensure that those services include mental health services, and that mental health services are not only curative, as we have seen, they ought to be promotive, they ought to be preventive, and ultimately then have access to care for those who eventually develop severe distress or mental illness that require treatment. But mental health must be a core part of the workplace culture, the workplace environment, and of the benefits that our health workers get. Thank you.
Thank you. Dr. Mercy?
Yes, for me, I want also to echo what has been said, that if we do not have healthy healthcare workers, then we don't have a functional health system. So the mental well-being of healthcare workers translates into health systems performance. And again, we must remember that it's not just the institution that has a mandate. You have a role as an individual towards your own mental well-being. Your supervisor, your immediate supervisor has a role, and the employer has a role. And remember also, as Prof has said, it's preventative, it's promotive, and it's also seeking help. So let us be part of the change that we are seeking. Thank you.
Thank you. So my parting shot would be that many a times we look at self-care as selfish. It's not. Healthcare workers need to prioritize their well-being. And from a study which we hope we can disseminate very soon, the things we need to do sometimes are very simple. Taking time off, drinking more water, sleeping a little bit more, seeking social support, and going for care when you feel overwhelmed. All these are really important, small little things we can do, even as we fight for the bigger change at the system level. So thanks everyone for coming to this webinar. It's been very insightful, and we look forward to discussing this study more as we publish more data and disseminate it. Thank you.
Thank you very much.
Thank you.